Each week, I hold one or two forums in the district on topics vital to your life. Here's another show that we taped.
So thank you all for being here, and I'd like to thank Senator Hannon's office for inviting me to come and speak to all of you. Thanks for coming despite the beautiful sunny day that I'm competing with. We haven't seen the sun in a while, so this is a treat today, I think. The topic that we will be discussing this morning is osteoarthritis. We'll cover several areas. We'll review what osteoarthritis actually is, the common symptoms, how doctors diagnose osteoarthritis. Also, we will go into some detail as to how osteoarthritis is treated. We'll go over things such as topical therapy, so creams that can be helpful for osteoarthritis. We'll go over different oral medications and different injections, and we'll briefly go over surgical treatment for more advanced cases of arthritis. We'll briefly go over some investigational therapies for osteoarthritis, and we'll end discussing some of the more holistic vitamins, nutritional type therapies that people try to use to treat their arthritic symptoms. So, osteoarthritis is the most common joint disease affecting middle-aged and older people. It occurs when the cartilage, the cushioning between bones, breaks down, which leads to joint pain, stiffness, and swelling. The most commonly affected joints, as one would expect, are the weight-bearing joints, the knees, the hips, and the lower back. However, osteoarthritis could also affect the fingers, as well as any joints that have had previous injury from trauma, infection, or episodes of recurrent inflammation. So cartilage, this is a slippery type of material or cushion that serves as the body's shock absorber. It reduces friction in the joints as the joints bend and move. So this is a picture of a typical joint. Here on either side are the bones. The cartilage is this shiny, smooth lining at the end of each bone. In between the two bones and the cartilage lining is a space that's filled with joint fluid that serves as a lubricant to allow the joints to move smoothly. When this cartilage is damaged or begins wearing away, the bones can come into contact with one another, so you lose this nice space in between, and this can limit movement significantly and cause pain, swelling, as well as significant functional limitation. Okay, so this is a common condition. About 27 million Americans have osteoarthritis, and this is really the most common form of joint disease. The lifetime risk of developing osteoarthritis of the knee is about 46%, so almost half of us will get arthritis in our knees. And the lifetime risk for developing osteoarthritis of the hip is a little bit less, about 25%. And as you would imagine, osteoarthritis is a top cause of disability in older people. So who gets osteoarthritis? Osteoarthritis affects people of all races and both sexes. Most often it occurs in people over the age of 40. It can occur sooner if you have Other risk factors, for example, people that have an inflammatory condition called rheumatoid arthritis can sustain damage to the joints, leading what is known as secondary osteoarthritis, or athletes who have had a traumatic injury to a knee or a hip, they can get osteoarthritis at younger ages. Other risk factors for the development of osteoarthritis include a genetic predisposition, so having family members with osteoarthritis could indicate that you may be at a higher risk for developing osteoarthritis yourself. There is a strong correlation between obesity and osteoarthritis. As you would imagine, especially with the weight-bearing joints, the extra weight can place increased stress on joints such as the hips, the knees, and the lower back, accelerating the course of osteoarthritis. Previous joint injury or repetitive overuse of joints can predispose to osteoarthritis as well. Other structural issues in the joints, such as an unequal leg length, if one leg's a little bit longer than the other, that can increase the risk of osteoarthritis. People who have bow legs or knocked knees, again, that causes increased stress on the joints and can accelerate osteoarthritis progression. Okay, so how is osteoarthritis diagnosed? So we suspect it when people have pain in the commonly involved joints, pretty straightforward. It can be confirmed by physical examination, which can show bony enlargement, firm kind of bone spurs that we see on the joints, fluid buildup, water on the knee, swelling can be seen. When we check the way the joints move, we can feel like a cracking or a creaking sensation, which normally shouldn't be there if the knee or the joint is particularly bad. We can even hear it. And there could be evidence of instability in the joint on exam as well. Things such as x-rays could be really helpful in confirming the diagnosis. And occasionally blood tests could be helpful to rule out other conditions. For example, if an unusually young patient comes in with symptoms that probably are osteoarthritis, but if you wanted to try to exclude another condition, something like rheumatoid arthritis, which would be more common in a younger population, blood tests could be helpful. There isn't a blood test to diagnose osteoarthritis, though. So this is what osteoarthritis looks like. On the upper left is a cartoon drawing of an osteoarthritic hand. Here in the circle is a diagram showing a normal joint with nice smooth contours of the bone and nice even joint space with the cartilage overlying the bones. On the right-hand side of the circle is an osteoarthritic joint where you can see the cartilage that's normally nice and smooth is gone. You get these rough kind of bone spur type areas. The joint is narrow and you get these bone spurs that form on the outer parts of the joint, and these enlargements would correspond to these bumps that we see on the fingers here in this picture. Here are some pictures of osteoarthritis affecting the hips and the knees. On the lower left is an x-ray of the pelvis showing both hips. With this hip, you can see a nice space in between the thigh bone and the pelvis. It looks relatively smooth, okay? If you look here, This hip has pretty severe osteoarthritis. You don't really see much of the bone space at all. This would be something that your doctor or the radiologist may describe as bone-on-bone arthritis in the hip. And as you would imagine, a hip that lacks a joint space such as this, there would be a lot of pain, limitation in motion, limitation in, really what this person would be able to do. Here on the lower right is a picture of x-rays of the knees. Here on the outer part of this knee, you see a bit of, a nice joint lining, nice joint space. But here, in the middle part of the knee, normally you should see this nice black space continue throughout the joint. This is not normal. These are, again, bones sitting on top of one another. And as you could imagine, the motion and function would be quite limited in a situation such as that. Okay, so treatment and prevention. So really there is no proven treatment yet that can reverse joint damage from osteoarthritis. So really the main goals of treatment is to reduce pain and improve function of the affected joints. This can be achieved by a mixture of physical measures, medications, and sometimes even surgery. Forms of drug therapy include topical treatments, creams, gels, we'll go into that, different oral medications, and finally injections, shots given directly into the affected joints. So weight loss and exercise are very useful and important in the treatment of osteoarthritis. So excess weight does put a lot of stress on the knees, on the hips, and the lower back. Losing weight could help people with osteoarthritis reduce pain and limit further joint damage. There was one study that looked at this, and what it showed in people that are overweight or obese, if they lose 10% of their total body weight over the course of 18 months, their pain improved by 50%, which is a significant decrease, better than even a lot of medications can achieve. Exercise is helpful as well. This can improve muscle strength, decrease joint pain and stiffness, and lower the chance of disability due to osteoarthritis. And, studies have shown that strengthening exercises can have effects of similar magnitude in terms of improvement in pain and function that even the prescription anti-inflammatory medications can. Okay, so pills for osteoarthritis. So oral pain relievers such as acetaminophen or Tylenol and different anti-inflammatory medications, the nonsteroidal anti-inflammatory drugs, or NSAIDs as they are called. These are common first-line treatments that are used, and we'll go into the NSAIDs in a little bit more detail coming up. In 2010, the FDA approved the use of a medication called duloxetine, otherwise known as Cymbalta, for chronic or long-term musculoskeletal pain from conditions such as osteoarthritis. This medication is interesting. It's used for other conditions as well. It was initially used as an antidepressant. It's also used to treat various causes of nerve pain as well as a chronic pain syndrome called fibromyalgia. And this drug is useful in people that have incomplete benefit from things such as the anti-inflammatories, or who can't take anti-inflammatories due to other medical conditions or side effects. And we'll, again, go through that in a minute. People with more severe pain or more advanced arthritis are sometimes prescribed stronger medications, including prescription narcotics. Okay, so these are the common NSAIDs, the common anti-inflammatory drugs, aspirin being the first one discovered, and these medications are all ultimately derivatives of aspirin. If you look on the list, some of these are over the counter, so ibuprofen, Motrin, Advil are common brand names. Naproxen, you know it under the brand name Aleve, pretty commonly purchased. The rest of these medications are prescription. Important to note, if a person is on a prescription level anti-inflammatory, you don't mix and match. So if, for example, a doctor has you on a prescription level medication called Voltaren, you don't want to supplement your prescription anti-inflammatory with an over-the-counter anti-inflammatory, because it will just dramatically increase the risk of side effects. So as I mentioned before, all of the NSAIDs are derivatives of aspirin. They diminish pain and inflammation. They do take a few days to achieve their maximum effect. It is best to take these medications with food, causes less stomach upset if you do that. The major side effects could be significant. Common things, heartburn, diarrhea, but also more serious things such as bleeding, stomach ulcers. These medications can also reduce kidney function. They could elevate the blood pressure. They can cause significant bleeding. Patients, like with any medication, could develop allergic reactions, rashes. Some people with asthma can find that these medications can worsen their asthma symptoms. There are a newer class of anti-inflammatories called COX-2 inhibitors. Celebrex is the one that remains on the market. May have some fewer side effects. There is a lower risk of stomach ulcer. It's not a blood thinner, so a little bit less bleeding with this. However, the effect on kidney function is the same as with the other anti-inflammatories, and with all of these medications, there is a class warning that long-term use of these medications can be associated with an increased risk of cardiovascular disease. So that goes for the prescription and over-the-counter versions of these medications. So, treatments with these medications should be tailored to each individual. A doctor needs to evaluate carefully a patient's medical history, their physical exam, and look at all of the other medications that a patient may be taking, including prescription and over-the-counter medications. For example, if somebody is taking a blood thinner called Coumadin or warfarin for whatever reason, these medications are not routinely given. Other heart medications, things such as Plavix or Eliquis, also have an effect of thinning the blood, and just to minimize the risk of bleeding. Again, people that are on those medications, the anti-inflammatories, are generally not recommended, even the over-the-counter ones. So talk to your doctors before starting anything like that. Okay, so moving on to topical therapy. So topical drugs are applied to the skin directly over the affected joints. And these include things such as capsaicin cream, which is over the counter, and diclofenac gel and patches, which are prescription. So capsaicin is the active ingredient making hot chili peppers hot and spicy. It's thought to work by depleting a pain-causing substance in nerve endings called substance P. People can have some improvement in their joint pain with continued use of this. A lot of people, about half, have side effects which limit the use of this treatment. Some people get a lot of redness, burning, and stinging of the skin where the medication is applied. And if you rub your eye after using this, it can cause redness and pain and discomfort. So could be helpful, but just be careful. So if you recall, on the list of prescription anti-inflammatories that I showed you before, there was a medication called diclofenac, which is offered as an oral anti-inflammatory. There is a topical version of this called diclofenac gel. The brand name for that would be Voltaren gel. And just like the capsaicin, you put it on the affected joint. It's been shown to be very effective in treating osteoarthritis in the knee and the hand. These are pretty superficial joints, so the cream doesn't have too far to penetrate in that situation. The risk of side effects is much lower with this, so there's less of the gastrointestinal, kidney, and cardiovascular risk compared to the oral formulations. Mild skin rashes are really the most common effect, but if somebody has osteoarthritis in a hand or a single knee, this is actually quite a nice option to have. Yes? It does. Okay, so moving on to injections. Generally 2 types of injections are given for osteoarthritis. Steroid injections, cortisone type shots, and something called hyaluronic acid can be given as well. The advantages of injection therapy for osteoarthritis is that it avoids systemic therapy. So, the anti-inflammatories with all of their side effects, you could avoid that. And the treatment directly targets the affected joint. The disadvantages of this, well, you can only treat one joint at a time. And the duration of benefit can vary. Some people experience exactly 0 benefit from a shot, and I've had patients be good for 6 to 12 months. So everybody's different in terms of the effect.
For one shot?
For one shot. There's a question in the back? Yeah, again, everybody's different with this. All right, so we'll go into a little bit more detail about steroid injections. So steroids are very potent anti-inflammatory medications, not derivatives of aspirin, unlike the NSAIDs, but they can relieve symptoms when they are injected into arthritic joints. These injections could be recommended for people with osteoarthritis confined to just a couple of joints and who still have pain despite the use of the NSAIDs, or who can't take NSAIDs for various reasons. Joint injections generally have very few side effects. Some people can experience a brief flare-up of arthritic symptoms after an injection. There is also a very small risk of introducing an infection into a joint, but that's very rare. These things are done under sterile technique, and the risk of causing a joint infection with an injection is very, very low. Steroids can damage certain joints if injected too frequently. So generally, doctors recommend no more than 3 to 4 injections per year for each particular weight-bearing joint, such as a knee. Okay, and moving on from steroids to the fancier gel injections. So as we touched on briefly before, normal joint fluid, it's thick, it's slippery, it contains a large amount of a substance called hyaluronate, which allows the fluid to be slippery. There are synthetic hyaluronates, such as Hyalgan, Synvisc. There are others, which can be injected into the knee to treat osteoarthritic symptoms. When it works, the pain relief can last for several months. There are studies that are looking at injections of this into other joints, but for now it has FDA approval for the knee. As with steroids, there is a small risk of introducing an infection into the joint, but it is quite generally a very safe procedure. So again, we mentioned bone-on-bone arthritis and the effect that it can have on a person's ability to function, and it's good to have the surgical options for these severe advanced cases. So surgery can involve arthroscopy, which is an attempt to repair the joint through small incisions made in the skin. However, in more advanced cases, such as with the bone-on-bone arthritis, that won't work. So if the damage is really beyond the point of a simple repair, a total joint replacement may be necessary. So here's a cartoon showing the before picture of a knee. You can see there really isn't much joint space. That smooth, shiny, nice cartilage that should be there is gone. And as you can imagine, this knee isn't moving very well at all. After a replacement, these worn out surfaces are replaced with different artificial components which are smooth and nice and move actually quite well, and this can restore a person's ability to function significantly. So basically, total joint replacement surgery, it's essentially perfected for the hip and the knee. The surgeons do this all the time. It's been shown over and over to decrease pain and to restore function. As with any surgical procedure, a careful preoperative evaluation with your medical doctor is important. You need to evaluate the different medical illnesses to try to minimize the risk of an elective surgery. Such as this, you want to look at the other joints as well. If a person has multiple joints affected with severe osteoarthritis, and it looks like several surgeries may ultimately be required, that would be important to know about and plan ahead of time. And the timing of the surgery, whether to have it or not, we generally leave it up to our patients. Different patients have different expectations of, the level of activity that they want to do every day. If somebody is more active, they're an avid tennis player, for example, and they love to play tennis, and they play tennis all the time, and their knee is so bad they're not able to do what they enjoy, they may opt to do surgery sooner than, someone who's maybe a bit more sedentary. They like to read, they like to knit, they like to go to the movies, have zero interest in tennis. For somebody like that, surgery can be delayed a bit, and it's really up to the individual to decide what would be best for them. So this is a before and after picture of a knee. Here, this part of the knee has a relatively normal joint space, but here in the middle, again, you can see these bones on top of one another, and this is after the replacement, where you can see the joint space opens up quite nicely and the person can function much better. I see some questions. So the question is, what if somebody has bad hip and a bad knee on the same side? So really we would leave it up to the orthopedist to decide which, in terms of functioning, has the more significant impact, and surgeons often have preferences in terms of the order that they would prefer to do surgery: knee before hip or hip before knee. Yeah, it could be challenging. So that's why I like a thorough, assessment before going for any kind of surgical procedure. It's really important. Yes? Again, the question is, how long does a knee replacement last? It depends on a lot of factors. So if somebody gets a knee replacement and, they're younger and they're more active, causing potentially more wear and tear on the knee, it would last less than in a person who's older and maybe a bit more sedentary. Other things that can impact the longevity of a joint replacement, things like obesity, being overweight, again, can impact the stresses placed on the artificial joint. Yes?
What is the meniscus and is it affected by arthritis?
Okay, so the question is, what is a meniscus and is it affected by arthritis? So a meniscus is a little kind of cartilaginous cushion in the knee. It can be damaged through injury, playing sports, wear and tear. A meniscus isn't necessarily affected by arthritis, but a meniscal injury or a damaged meniscus could be a predisposition to the development of accelerated osteoarthritis. And if there's a damaged meniscus without significant osteoarthritis, it's under those conditions that sometimes the surgeons would, try to do the repair, the arthroscopy, rather than a full replacement. All right, so we're going to go from approved treatments to more investigational approaches for osteoarthritis treatment. So currently in clinical trials is an antibody called tanezumab, which targets pain in osteoarthritis by inhibiting something called nerve growth factor. And it's being studied to see if it can improve the chronic pain associated with osteoarthritis. That's an antibody, so it's given by injection. And these next three things, platelet-rich plasma, stem cells, and prolotherapy, these are all injections into the joint. These are not FDA approved for the treatment of osteoarthritis, but you may see certain sports medicine practices or orthopedists doing this. I know there are several groups that are out advertising these things. So first we will talk a little bit about platelet-rich plasma. Again, this was initially developed from orthopedic applications. It's used to treat injuries to tendons, ligaments, and joints, and there is research now that's ongoing to see if there's benefit in more chronic joint conditions such as osteoarthritis. So platelet-rich plasma is derived from a patient's own blood, with platelets being the main constituent. So this is a very simple way showing how this works. So you have your blood drawn into a tube. The tube is spun in a machine called a centrifuge, and after spinning, the blood spreads out into different layers. Here are the red blood cells, here is only plasma, and then here in between is a platelet-rich layer. The platelets are harvested and then injected into the joint. The way it's thought to work is it does provide high concentrations of growth factors and other proteins which could reduce inflammation in an osteoarthritic joint. So there haven't been a lot of great trials looking at this in osteoarthritis. So there was a meta-analysis done in 2015 that looked at 10 different trials using platelet-rich plasma injections in patients with osteoarthritis of the knee. And they did find a significant difference in pain after these platelet injections. However, these weren't great studies. The majority of the trials had a high likelihood of bias, and only one of these 10 studies compared platelet injections to placebo or a dummy type medication. And also, limiting the assessment of this, there was a lack of standardization of the preparations of platelet-rich plasma amongst all the trials. So really more study, it's interesting, I think it has potential, but you really need better, more standardized studies looking at this before the use of this modality can be used in osteoarthritis. Okay, the next investigational, yes, question? Oh, we have a whole section coming up. Something I get asked about all the time. All right, so prolotherapy. This involves the injection of an irritant solution, usually a combination of dextrose and lidocaine, into joints, ligaments, and tendons with the goal of stimulating a repair response. And just like the platelet-rich plasma story, prolotherapy suffers from a lack of well-designed, large, randomized trials, especially with long-term follow-up. And, again, it's not included in any sort of professional guideline for the management of osteoarthritis just because of this lack of evidence. Also, it's expensive and not covered by insurance. Okay, so finally, stem cells. Stem cells have the ability to grow into different types of cells and can replace damaged, disease, or defective cells. For injections to the knee, doctors often take stem cells from the patient's own bone marrow, fat tissue, or blood. So, basically the way this works is the stem cells are harvested, they're expanded in culture, they can be processed in different ways and then injected into the joint. So stem cell therapy can reduce joint pain and inflammation. The exact mechanism of how they do that, it's really unclear. So there's a lot of active research that's ongoing. So researchers are studying whether the stem cells themselves can reduce inflammation or if they release substances, chemicals that can affect other cells. And there's a lot of research being done as to whether these treatments can regenerate worn out cartilage. So this is expensive, several thousands of dollars per treatment. Seems to be average, again, not covered by insurance, and the pain-reducing effect generally only lasts about 6 months with these treatments. And again, not approved for treatment of osteoarthritis, but this is an area of ongoing research. Some of the larger university centers, I know Joint Disease Hospital for Special Surgery, I know they participate in clinical trials looking at some of this in a more rigorous way. Okay, vitamins and supplements in the treatment of osteoarthritis. I get a lot of questions on this from my patients. So vitamins and different nutritional supplements are, sometimes used by patients alongside more conventional medical therapies for arthritis. These therapies, they're very attractive. They're perceived to be safe and natural. However, many of these treatments are marketed with unproven claims, and certain therapies can be harmful. So just because something is quote unquote natural doesn't guarantee that it's safe. So to ensure safety and to avoid drug interactions, definitely consult with your doctor before using any of these agents at all, especially if you're on any sort of prescription medication. So vitamins. So the role of vitamin supplements in the treatment of osteoarthritis, it's unclear. So there has been a lot of research focused on the antioxidant vitamins, vitamin C and vitamin E, as well as with vitamin D. And so there have been a bunch of trials that looked at supplementation with these vitamins for osteoarthritis, and they really haven't found any significant benefit either in pain or prevention of disease progression. Glucosamine and chondroitin, so, the use has been a little bit controversial. There have been several randomized trials, the results of which have been varied. Glucosamine typically has been studied at a dose of 500 milligrams 3 times a day, and chondroitin 400 milligrams 3 times a day. The preponderance of evidence on glucosamine and chondroitin, either taken separately or together, it does come in combination, indicates little or no meaningful pain improvement or functional improvement in osteoarthritis. However, there appears to be very, very few risks associated with their use. Some patients, I believe, do find it helpful. So, with my patients, if somebody asks me, if they could try it, there's generally not a significant downside. If it helps, great. If not, stop taking it. Just important to know that glucosamine shouldn't be used in people that are allergic to shellfish because it's derived from shellfish. First, we'll cover fish oils and plant oils. So fish oil contains a high amount of omega-3 fatty acids, which the body can use to make substances that reduce inflammation. There are certain plant oils, such as primrose oil, borage, black currant, and flaxseed oils, which contain both omega-3 and omega-6 fatty acids. So clinical trials of fish oils and the plant seed oils have suggested a very modest decrease in arthritic symptoms. However, fish oils can interact with blood pressure medications, potentially lowering the blood pressure too much, and they can increase the risk of bleeding, especially in people that are taking aspirin or a blood thinner called warfarin or Coumadin. The plant oils can also have potentially dangerous side effects, including increased risk of bleeding with borage seed and primrose oils. They can also interact with psychiatric medications, especially primrose oil. And borage seed oil has been associated with a worsening in liver function, so you need to be careful. Okay, now herbs. So herbal treatments have been promoted for arthritis for a very long time, and these include things such as ginger, turmeric. The active component is curcumin, something called devil's claw, avocado soybean unsaponifiables, or ASUs, and something called boswellia. Although some small studies suggest that a few herbs, such as ginger, ASUs, and boswellia, might have some small benefit for osteoarthritic symptoms, the overall evidence is fairly weak with this. Standardized preparations aren't available. Again, these aren't looked at as medications by the FDA, so they don't have the same strict guidelines that prescription and, this more standard over-the-counter medications do. And there is a general lack of safety data available for many of these herbs. So again, talk to your doctors. Be careful with interactions. Okay, and finally, this is probably the most common question that I get at least once a day from my patients. Is there an anti-inflammatory diet for arthritis? And sadly, the answer is no. It would be great if there were, but there really is no compelling evidence that any diet other than a healthy, balanced one is consistently helpful to patients with arthritis. For example, a study of a popular diet which included the elimination of red meat, additives, preservatives, certain fruits, dairy products, herbs, spices, and alcohol. I don't know what was left. For patients with arthritis, really found no effect whatsoever on disease activity. So other than the healthy, well-balanced diet that we all know we should be eating, there really isn't anything proven to, help arthritic symptoms. And that's it. Thank you all for your attention.